अगला कदम आज स्थापित हो। बहुत बहुत दोनों स्पीकर्स का बहुत बहुत धन्यवाद। नमस्कार। ओवर टू प्रोफेसर पवन शर्मा।
नमस्कार, स्वागतम, बहुत बहुत आभार। मैं आदरणीय डॉक्टर सुभाष चंद्र वाजपेयी सर का स्वागत करता हूं। डॉक्टर श्रीनिवास मणिगोल जी का स्वागत करता हूं और दो स्पीकर डॉक्टर अजीत खालकर जी जुड़ चुके हैं और मेरे हिसाब से डॉक्टर शिवपुत्र जी भी हमारे साथ हैं। मैं उन सभी का हार्दिक स्वागत करता हूं। टुडे we are celebrating 10th day of Maharishi Sushruta Jayanti, and Dr. Srinivas K. Vanigolji from Hubli, Dr. Shivaputra Valreddy ji from Bagalkot, Dr. Ajit Khalkar ji from Nasik, and as usual, Dr. Mahesh Sanghvi ji from Mumbai will guide us on different topics of surgery, Shalya, and Sushruta. Thank you very much. Welcome again. I don't know who is trying to join as Zoom user. I don't know. Ajit Khalkar ji is trying to join. I would like to request Professor V.K. Agnihotri sir for welcome.
Thank you, Professor Pawan Sharma ji. I'll just invite Professor Dr. Mahesh Sanghvi sir, if he is now available, because this section belongs to him, and if he is not, as per his choice and guidance, we have got selected surgeons to present their guest speeches on our 855th webinar in the continuation of on 10th day of Maharshi Sushruta Jayanti Shankhala series. So, Dr. Srinivas Bangali is very much here. Rest speakers will join in a sequence manner. I think please just say a few words regarding your field of specialization out of the surgery as such, and then I would like to request you to please start with your presentation, sir.
So, good evening, sir. You are requesting me to start. Namaskar. Namaste, sir.
Welcome.
Namaste, sir. So, on the eve of Maharshi Sushruta Jayanti celebration, this AYUSH SAMRIDDHI webinar, I extend my warm wishes to all the organizers and participants of this webinar. At the outset, I would like to extend my sincere gratitude for giving me the opportunity of sharing my experiences with all the participants as well as the stalwarts of Ayurveda Shalya Tantra. At the outset, I extend my gratitude and thanks to Dr. Mahesh Sanghvi sir for inviting me to deliver a lecture on, of course, the subject was mentioned as Chara Sutra, but he has asked me to talk on Rakta Mokshana Karma. So my topic today will be on the Rakta Mokshana, my little bit of practical experiences in the management of few diseases of Rakta Mokshana. I would like to share my screen. Share. Desktop. I hope my screen is visible, sir.
Yes, sir, you are visible, audible, both loud and clear.
Okay, thank you, Sangvi sir. The topic is very small, but its clinical importance is very much present in the present era. It is having its own significance. That is, I would like to share my views on. That is, I move out of share. Next slide. I start with the very basic things, that is the types of chikitsa. Chikitsa is broadly classified under two headings, Shamana chikitsa and Shodhana chikitsa. Whenever in a disease, alpa doshas are there, the clinician opts for Shamana chikitsa. If a bahudosha avastha is there, then invariably he has to opt for Shodhana chikitsa, that is Karma chikitsa. All of you aware that Charaka mentions 5 Shodhana procedures: Vamana Vilechana, Niruha, and Anuvasana Baste, Nasya Karma. But Sushruta in his text, instead of separating Niruha Baste and Anuvasana Baste, he combines it as a Basta Chikitsa and adds one more Shodhana Chikitsa, that is Rakta Moksha. So, Sushruta, being a surgeon, he has given more importance to Rakta Dhatu. When you look into the text of Sushruta Samhita, on various instances, it seems that he has given the place of Rakta up to the extent of Chaturtha Dosha. So, he thought that Rakta as a Dhatu is going to play a very important role in the manifestation of various diseases. Even though Rakta is a Dhatu, the Chalana of doshas is basically from the Rakta Dhatu, majority times. Hence, whenever the doshas are in Pravruddha Avastha, one of the route of removal of these doshas through Rakta Dhatu. So, he has considered Rakta Mokshana as one of the Shodhana Upakrama. And literally, Rakta Mokshana means the removal of the blood from the body. But actually, we are not removing the Shuddha Rakta. Here, we are removing the vitiated Rakta. Because blood is a very vital physiological factor in the body. Sushruta has mentioned, Raktam Jiva Iti Smrutihi. Blood is life and it cannot be let out. But whenever there is a vitiation of doshas are accumulated in Rakta Dhatu, and these doshas can be removed from Rakta, from the body. And if this vitiated Rakta is allowed to remain in the body, then it is going to produce a lot of hazardous diseases. Hence, in a given time wherever the Pravruddha doshas are there, Rakta Pradushaja Vikaras are being manifested, it becomes essential to remove the Rakta from the body. Sushruta in his text, he has mentioned 5 to 7 types of Rakta Mokshana Prakaras has been mentioned. 5 types mainly. And he classifies broadly them as to Shastrakruta and Anushastrakruta, Ashastrakruta. In Shastrakruta, 2 types are there. There are Prachanna and Siravedana. And in Anushastrakruta, Jalavakavacharana, Sringavacharana, and Alabhavacharana have been mentioned. And there is another two types are there. One is the Ghati Prayoga, by which Rakta Mokshana can be done. And nowadays, by cupping method also, the Rakta Mokshana is being in practice. But SUSHRUTA has mentioned these types of Rakta Mokshana in his text. And all these types have been indicated in a very specific condition or diseases. And indications and application of these 5 types of Rakta Mokshana has to be applied depending on dosha avasthanusara, which dosha is predominant in the Rakta Dhatu. For example, if Pitta dosha is predominant, then Jalokavacharana has to be used because Jalokas are Shita in nature. If Vata dosha Prakopa is there, then Shringavacharana has been mentioned because Shringa is Snigdha and Shita Guna. And if Kapha dosha Pravruddha is there, then Alabhu Avacharana has to be done because Alabhu is Katu and Tikshna. So hence it helps in pacification of Kapha dosha. Apart from dosha avasthanusara, even Rakta avasthanusara has also to be considered. Whether the Rakta is superficially situated, it is avagada, or deeply situated, or it is all over the body, Vishita Rakta is there. So accordingly, these 5 types of Rakta Mokshana prakaras are to be adopted. And also, Atura avasthanusara, if the Atura is very Sukumara, instead of Shastrakruta Rakta Mokshana Vidhi, we have to adopt Anushastra Kruta type of Rakta Mokshana. Now here, I am concentrating on only 2 types of Rakta Mokshana prakaras. One is Jalokavacharana and the second one is Siravidha. So in my presentation, I will be more concentrated only on these 2 procedures, that is Jalokavacharana Dwara Rakta Mokshana and Siravidha Dwara Rakta Mokshana, because majority of the Ayurvedic physicians or surgeons, they are in their clinical practice, they are adopting these 2 procedures optically. That's why I'm concentrating on these 2 types of Rakta Mokshana. Jalokavacharana, as you know, Jaloka is leech, Hridino medicinalis species leech is used. It is called as Jaloka because the Ahara and Janmasthana of Jaloka is Jala. That's why it's called as Jaloka. And there is a mention of 6 types of Savisha Jalokas and 6 types of Nirvisha Jalokas. And Nirvisha Jalokas are used for the purpose of Rakta Moksha. In Sushruta Samhita, there is an elaborate description of how these Jalokas are to be, Sangraha has to be done, how they have to be collected, how they have to be preserved. Because whenever the patient comes, we must be ready with the Jalokas to use it in that particular patient. So he mentions Grahana Kala, when they have to be collected, it has to be collected in the Sharat Kala, because Sharat Kala there will be Hamsodaka, pure water is there, and these Nirvisha Jalokas always will be there in very pure water. That's why at that time we have to collect it by various methods that have been mentioned. Then they have to be kept in an earthen pot. We have to feed them and we have to change the water 5 to 7 days. Nowadays, as the fish aquarium are there, in the same way, we have made aquarium that is for Jalokas. We have got the aquarium wherein we can keep the Jalokas and can be used where and when they are required. And as these Jalokas are Shita in nature, because always they stay in water, hence they are used in Pitta Vikaras wherever in Rakta Dosha, Rakta Dhatu, Pitta Dosha is predominant. At that time, Rakta Mokshana by Jalokas are to be used, and Rakta Sthiti in the body is Avagada Sthit, that is even little bit of deep situated Raktas can also be removed. And Jalokasaha to Parama Sukumaropaya Drupa Adya Balas Tavira Bhiru Durbala Nari. So it is a Shastrakruta type of Rakta Mokshana, because and it is painless. Many patients will be having the fear of subjecting themselves to the various surgical instruments or surgical procedures. So the jalokas are to be used in Parama Sukumara Upaya, where very Sukumara Prakriti, like Nrupa, the king Adya is having a lot of money, Bala, children, Sthavira, that is aged, one has got the fear for the procedure, surgical procedure, Durbala, weak, and in Nari, in Strees, these Jaloka Ucharana can be used because Raktamokshana by Jaloka is basically without inducing any pain. And broad indications for Jaloka Ucharana is Gulma, Arsha, Vidhrari, that is abscess, Kushta, Vatarakta, Galarogas, various Netrarogas, Visha, and Visarpa. These are broadly indicated for Jaloka Ucharana Vidhi, and in these conditions, the effective results can be obtained by performing Jaloka Ucharana. Before using these Jalokas are to be subjected for Shodhana Karma, because the aim of performing Shodhana Karma is Shuddha Utpatti. Once the Jalokas suck any blood, so they can survive months together without any food. So to make them to bite and suck the blood, we have to induce appetite in the Jalokas, and Krama, they are having RSEs or Krama, laziness. So we have to do the Shodhana, for which the Jalokas are kept in Haridra Churna, Haridra and Sarshapa Jala for 1 Muhurta, so that then it becomes very active, Shuddha. Then from Mandagami to Shigragami, when it becomes Rakta Achushan Ichha is there, it moves around, and then we should call it as Shuddhi has taken place. Then we have to apply. The detailed description of how the application of Jaloka has to be made has been explained in detail in Sushruta Samhita. I am not going in detail of that one. We have to make the Jaloka to bite on the area where we want to remove the Rakta. Jalokas, if they don't bite, we have to take a small incision, and then the Jaloka will fix, then it starts sucking the blood. So in Jaloka Ucharana, with my experience, I am giving you that Jaloka Ucharana in one condition of anorectal disease. And some points we have to keep it always in our mind, that before subjecting a person to the Rakta Mokshana, any type of Rakta Mokshana procedure, we have to subject him for the investigations of that he should not be suffering from any bleeding disorders, or he should not be under the medication of any blood thinners. Under such circumstances, when we do the Rakta Mokshana, then stopping the Rakta Srava becomes very difficult. So before subjecting any individual for Rakta Mokshana, we have to see that the patient is not taking any blood thinner drugs like aspirin or something like that, ecosprin or something like that, and his bleeding time and clotting time has to be observed, and whenever, if the bleeding disorder is not there, in those subjects only we have to apply Jaloka Ucharana or any type of Rakta Mokshana. So the leech application should be done preferably in the daytime, as sometimes even the Jalokas are removed from that particular area, the bleeding will persist. If the patient sleeps and during the night time, he may start bleeding without the knowledge of the patient. Hence, it should be always done in the daytime. So in certain places, application can be done by using a glass tube, because when you are using it in the diseases like Netra Rogas, so we have to use a specific instrument through which, through the glass tube, we have to introduce Jaloka, and there you have to apply. Leeches once used can be used again after 7 days, because we are doing the Shodhana of leeches, then we are applying it. Leech application improves local circulation and enhances the vascularization. That is the effect. Hence, effectively used in chronic and non-healing ulcers, diabetic ulcers, etc. That will come to later on. The saliva of this Jaloka contains more than 12 to 14 constituents. Very few are understood so far. We have understood that the saliva contains a substance alike to hirudin, which is anticoagulant. It contains a substance which induces anesthetic effect. So whenever Jaloka bite is there will not be any pain. The person will not come to know that Jaloka is biting, because initially it releases an anesthetic-like substance, so that there will be local anesthetic effect will be there, and it can suck the blood very easily because it got hirudin, that anticoagulant. Blood is not coagulant. Well, blood will not clot, and it contains an antibiotic type of constituent. Histamine-like substance is also there. It induces vasodilatation, and proteolytic inhibitors are there in the saliva of Jaloka. Apart from various other constituents are there, which are of having effective in this thing. So after the Jaloka Charana, when the Jaloka sucks the blood, Paschat Karma of Jaloka is most important. It is told in the text that by the Swabhava of Jaloka, initially the Jaloka sucks the impure blood from the site. And when the person starts getting kandu or little bit of itching sensation in that area, then we have to understand that Jaloka has started sucking the pure blood. It is very astonishing that how the Jaloka initially sucks only impure blood. That cannot be explained. But Sushruta, he explains by giving an example that Hamsa Pakshi, how it takes in a water mixed kshira, it takes only the kshira, leaving behind the water. In the same way, the Jaloka initially sucks the only impure blood, and later on it starts sucking the pure blood. So when the person experiences little bit of Toda or Kandu at the local site, then we should understand that it started sucking the pure blood, then Jalokas are to be removed. So after removing the Jaloka, on the rogi, we have to apply some Shatadauta Gruta or some Raktastambhaka Churnas, because even the Jalokas are removed from that place. Sometimes the bleeding starts oozing, then we have to apply the bandage. And for Jalokas, as they have sucked the impure blood, if it is not vomited out from the Jaloka, it leads to a disease, a dreadful disease called as Indramada, and by which the Jalokas are going to die. So that's why Sushruta has mentioned that whatever the Jaloka has sucked the blood, it has to be made vomited from the Jaloka, so that the Jalokas are prevented from suffering from this Indramada Vyadi. So now I will be explaining the management of a kind of an nurses by Jalokavacharana. So Jalokavacharana is used in a thrombosed external pile mass. This thrombosed external pile mass is also called as a perianal hematoma. In few conditions, wherein there is in the perianal region, beneath the anal skin, the capillary bleeding will be there, and this capillary bleeding is accumulated beneath the skin, and it becomes clotted. That is called as a perianal hematoma. It gives a little bit of more pain at that condition. Or whenever whenever there is I'm getting echo. Hello, sir. Some echo is there. So whenever there is a thrombosed, prolapsed and thrombosed hemorrhageal mass is there, in that conditions also we can apply the Jalokas. Now I will show you some of this is an inflamed hemorrhoidal mass. So here also we can apply the Jalokas and do the Raktamokshana, so that pain will subside immediately and the swelling and thrombosis will also. This is a 3 o'clock thrombosed pile mass, wherein we have to apply the Jaloka. Jaloka will suck the blood. It relieves dissolves the hematoma, and the pain is reduced and swelling is also reduced. So instead of taking an incision and making an evacuation of the clot very easily by using Jaloka, we can subside. It is another thrombosed pile mass. Here is also we can apply the Jaloka by which. So in thrombosed hemorrhoidal masses, Jaloka Ucharana is done by which the pain will subside and the dissolution of the hematoma takes place because the saliva of the Jaloka contains a hirudin. It's an anticoagulant, so it dissolves the clotted blood and it sucks it out. Doesn't give any pain while biting, and even after biting, the anesthetic drug will remain in the local area, and even after removing the leech also, the pain will not be there, and there will be some antibiotic effect will be there. So benefit of Jaloka Ucharana in thrombosed hemorrhoidal mass is it relieves the pain instantly, and regression and resolution of the mass will take place. Now, in another conditions, so this is the procedure of how Jaloka Shodhana is done. I think the time is not there. I will skip this. Everybody knows. So this is the severe cellulitis. In cellulitis condition, the Jalokas are being applied here. They will suck the blood and cellulitis will reduce. This is in Vranashofa, acute cellulitis. So this is the Dushta Vrunas are there. Diabetic, it's a diabetic wound. So we have applied multiple times of the Jaloka Ucharana. Apart from Jaloka Ucharana, we have used other medications also. So this is completely healed by application of Jalokas. Next is Dushta Vrunas, various types of Dushta Vrunas. Application of these Jalokas is very much beneficial. And that's why how it's going to act will listen. Apart from this, on Janu Sandhi Shota also. In Sandhi Shota also, you can, if you apply the Jalokas, so the Shota will reduce and the pain will also reduce. So in these conditions also we can use the Jalokas. So after Jaloka here the Vamana is done and Shodhana of Jaloka is done. So the probable mode of action of this Jaloka Ucharana is it induces anesthetic effect. So it's a painless condition, and expresses anti-inflammatory effect is there because it contains various constituents wherein anti-inflammatory effect is there. Because of the anticoagulation, the blood is circled well and it improves the circulation. Normalization and improvement of the capillary circulation takes place. Blood purification by expelling out the vitiated blood will happen, and the blood pressure, local pressure in that area is reduced, and the viscosity of the blood is enhanced, so that the circulation improves and it induces positive hemopoietic effect. So all these, whenever we remove some blood from the blood body, even if you give the donation, the process of formation of fresh blood will be enhanced in the body. And apart from these conditions, nowadays, whenever the skin grafting is done, if we feel that skin grafting is being rejected, at that time we have to, if we have apply the Jalokas, in such condition, the rejection of the skin graft can be prevented because Jaloka improves the capillary circulation, new capillaries are formed, so improves the circulation. Hence, the use of Jalokas in these conditions, particularly thrombosed hemorrhoidal masses, inflammatory conditions, joint swellings, as well as non-healing ulcers, Jaloka Ucharana plays a very important role. So this is my experience as far as the Jaloka Ucharana is considered. The next thing is I'm coming from is the Rakta Mokshana by Siraveda. Siraveda, as the name itself indicates, the Rakta Mokshana is done by puncturing the Sira. The Siraveda is considered as in Shailit Tantra, considered as Ardha Chikitsa, as Basti is considered as Ardha Chikitsa and Kaya Chikitsa. In Shaila Chikitsa, Siravedam is considered as Ardha Chikitsa. SUSHRUTA mentions that in any disease, if it is not cured by Snigdha Upakrama or Sneha Upakrama or Ruksha Upakrama, by Guru Chikitsa or Laghu Chikitsa, then Raktam Siraveda is going to help in this particular condition. So for Siraveda, the various instruments used are Kutarika Shastra, Vrihimuka Shastra, and Trikurchaka Shastra. Now, before performing Siraveda, as it is a Shodhana Upakrama, Snehana and Svedana is utmost important as Purvakarma Vidhi. Tatta Snigdha Svinna Maturam, Snehana and Svedana, Yantraitva, then we have to tie the tourniquet, not too tight or too loose. Then Sira Utthana will take place. Then Siraveda has to be done by appropriate Shastra. Sira Vidyastu Dushtamagre Pravartate. Once again, as it has been told in Jalokavacharana, that initially the Dushtarakta Jalokas are going to set. In the same way, whenever we perform the Siraveda, after subjecting the patient for proper Snehana and Svedana Upakrama as Purva Karmas, when we do the Vedana, initially the Dushita Rakta will come out. And later on, this Shuddha Rakta Srava takes place. And if the proper Siraveda has been done, Samyak Shastra Nipatena Sravetasru, Samyak Gatva Yada Raktam, Swayam Tishtati. So in a proper Siraveda, when we do it, after doing the Siraveda, the bleeding will stop on its own. This is the when we have to understood as that we have done it, a proper Siraveda has been done. Next, Siraveda, I am going to explain you because we have been doing a lot of work with Siraveda in Sira Granthi. That's a varicose veins. Sira Granthi is a condition where the siras of the lower extremities become Granthivat by Sampidya, Sankocha, and Vishosya. That is a varicosity. The main causative factors of weakness of Sira and Vata Prakopa, all this Sankocha, dilatation, tortuousness, and of the veins takes place. There will be Rakta Sanchaya in Siras, and initially there will be no pain, but as the disease progresses, it leads to various complications like ankle flare, and there will be formation of the varicose ulcers also. And the disease is very similar to that of a condition of varicose veins. So this is the procedure of Jalava. We're trying it out.
तू लावला का ते हो ते तुम्ही करू नका अच्छा हा काढू नका पिन नका काढू अरे आता चालू होतो ना आवाज याचा
Vastrapattam, though we are tied the tourniquet.
Dr. Ajit Khalkar ji, please keep your mic mute.
We made the
We request everybody to mute your mic except sir.
He's explaining the procedure to the patient, what we are going to do. Now, you have to give support at the sole that now the weather is being done. So immediately the blood will start oozing. About 125 ml of blood is being let out. Now we have to loosen the tourniquet. almost 125 ml of blood is removed. Now we have to stop the blood bleeding. Now apply the bandage. So this is the procedure what we have done. In case there is another video of the procedure. Here is also same after the application of the tar liquid. So weather is done here. Let's start oozing. Again 125 ml of blood will be collected.
Without proper instrument of ತೆಗೆದ್ರೆ ಸ್ವಲ್ಪ ಪ್ರೆಸ್ ಮಾಡಿ ಅಷ್ಟೇ ಸಾಕು ಸಾಕು ಸ್ವಲ್ಪ ಹಿಂದೆ ಇದೆ ಬ್ಲಡ್ ಬಿಡ ಮಾಡು ಕ್ರಾಸ್ ಅಲ್ಲಿ.
So after 125 ml of blood removed, so this is the procedure of Siraveda. These are some of the pictures of the patients of varicose veins before and after the treatment. So here also lot of varicosity was there. Now it has been reduced here after the treatment. This is another case. Before tortuousness was Sira was there, then afterwards it has been reduced. So this is another case. So the Siraveda in Siraja Granthi has got very good effects. Probably how it acts, because in Sira Granthi vitiated factors are Rakta and Vata. Removing stagnated Rakta from the Sira, Vata Avarodha is released. Hence, Chalaguna of Vata improves the blood circulation. By reducing the pressure in the Sira, the Vedana will also subside. Stagnated blood is removed. The breakage of RBCs gets reduced. Hence, the dark pigmentation and itching in that particular site is reduced. So, the conclusion. Before concluding, I would like to say that Siraveda, after doing the Siraveda, some doshas will remain, and the disease treatment, that Shamana Chikitsa, has to be continued. Even it may be Arshas, or it may be Vrunashota, or it may be Dushtavruna, or it may be Sira Granthi. So we do the Rakta Mokshana Krama, but along with that, Shamana Chikitsa, that the Vyadhi Prattanika Chikitsa has to be done. Specific treatment for those treatment has to be continued. So Rakta Mokshana is an unique Shodhana Chikitsa Krama. The vitiate doshas are removed through Rakta, which helps in curing of the diseases. Jalavakacharana and Prachana, the simple, and here Jalavakacharana and not Prachana, it's Siraveda, are simple, safe and date care procedures. Siraveda particularly involves the risk of Atirakta Srava, hence proper care has to be taken. The diseases like Vrunashota, Visarpa, Vidradi, Dushtavruna, Vicharchika, Sira Grantha can be effectively managed by Rakta Mokshana Chikitsa. With this, I conclude my presentation. Thank you everyone for giving me this opportunity of sharing my few experiences in the procedure of Rakta Mokshana. Thank you.
Thank you very much, sir. And oblige, थोड़ा मिस्टेक हुआ था मेरे से आपके विषय के लिए, लेकिन आपने उदारता से माफ किया। हर की समझते रहो, मैं आपसे माफी चाहता हूँ। सर को मैं 1981 से जानता हूँ। फर्स्ट टाइम भी हम बेलगाम में मिले थे, वहां से उनकी यात्रा भी बहुत लंबी रही, बहुत अच्छी अच्छी पोस्टों पे रहे। और किसी ने मेरे को पूछा था कि डिप्लोमा इन सारसूत्र गवर्नमेंट का कोई सीसीआरएस का कोर्स है, तो सर ही उनके जो है मेन उस कमिटी के चेयर थे और उन्होंने ही वो डिजाइन किया था। इज ए वेरी स्पोकन मैन, वेरी हम्बल मैन, विच आई सिंस नो हिम, एंड आई एम thankful to him, and he's always been happy to promote Ayurveda national, international. Thank you very much, sir.
Thank you, sir. Thank you very much.
अभी आप क्वेश्चन आंसर कर लेना है कि you will be like to wait for till end? What you want?
As you like, sir.
अगर आप टाइम है तो बैठिए सर, मजा आती है, दूसरे को भी सुनेंगे आप।
मैं I am interested. I will be there.
Thank you very much. So अजीत खलकर।
यस सर।
आप लास्ट में बोलेंगे, बैलेंद्र को कहीं जाना है, इफ यू अलाउड हिम।
बिल्कुल बिल्कुल।
आप स्क्रीन स्टॉप करो। बैलेंद्र, यू कैन स्टार्ट योर प्रेजेंटेशन। He was the introducer of Balendri. You stop your sharing, Ajit. Balendri, you share yourself. Ajit, you stop your computer, beta. Khalkar. Balendru. Why are you not listening me? You allowed to share your screen. नहीं तू कर, वो अजीत निकल गया है, आप करोगे ना अभी? You would like to do now or wait? Share yourself. Ajit, please withdraw yourself.
Sir, I am not sharing.
But your name is there on the screen. I don't know how and where. मुझे इतना सारा समझता नहीं है आपका टेक्नोलॉजी. And thank you for patience, बेटा. अजित खालकर का भी मेरे से विषय गलती हुई है. He will have very present and a very rare case in the perianal cyst, and he has presented at Cairo and he was appreciated national, international. So now Dr. Balendru is there. I met him due to the Samruddhi in Ilakkal, and then we are with touch with him. He is a very good practitioner and very good. He has the work in Agni Karma, but he has decided the SUSHRUTA as an endocrinologist. तो आजकल जो हम लेप्रोस्कोपिक ऑपरेशन कर रहे हैं उसमें भी उनका बहुत बड़ा कंट्रीब्यूशन है. तो उनकी नजर से सुश्रुत जी कैसे एंडोस्कोपोलॉजिस्ट है वो हम देखेंगे. बलेंद्रू, प्लेटफॉर्म इज योर्स. Your slide is there, your voice is not there. Where you stuck up, beta? Unmute yourself. एनेस्थेसिया देने के बाद में एनेस्थेसिया देने के बाद में सर्जन को इतना टाइम नहीं लगना चाहिए.
Can you listen?
ये तुम्हारा मोबाइल बंद करो, डबल आवाज आ रहा है. मोबाइल बंद करो, ओनली लैपटॉप यूज करो. थैंक यू. स्टार्ट योरसेल्फ, अनम्यूट योरसेल्फ फर्स्ट.
Hello.
Yes, you are audible, loud and clear. Please start, beta. Please start.
Sir.
Everybody mute yourself, and you also mute all your electronic gadgets in the room.
Okay, sir. My topic is SUSHRUTA as an endoscopist. The thing is, He is the pioneer in endoscopy, and to the my understanding, he is.
बालेंद्र, तुम्हारा कोई भी गैजेट चालू है, मोबाइल को स्विच ऑफ करो, या तो तुम दो जगह से ज्वाइंट हुए हो।
हाँ सर। Hello. Now is it okay?
Yes, excellent, very good, thank you very much.
Sir, and I'm very much thankful to you for giving me this platform to give my talk. And sir called.
पवन, क्या कारण हो सकता है?
Is it okay now?
Yes, yes, yes.
And it was very much when sir told that you are going to speak for 15 minutes. Sushruta, speaking on Sushruta as an endoscopist, it takes a long
Belendru,
time.
I request you find out yourself, still echo is there.
आपके कमरे में 2 डिवाइस खुली है, एक बंद कर दीजिए तभी होगा ये।
लैपटॉप
मोबाइल कहाँ है तेरा? मोबाइल पे से भी ज्वाइंट हुआ है क्या बेटा? मोबाइल को स्विच ऑफ कर दो, या तो एरोप्लेन मोड पे छोड़ दे बेटा।
Hello.
Yes. Now you speak loudly and then we can confirm you. Your voice is not there still, beta. If you require more time, should we allow Ajit Khalkar? Can you listen me, Belendru? Ajit?
Yes, sir.
इसको हटाकर अपन नहीं कर सकते, जब तक वो क्लोज नहीं करेगा तब तक तू नहीं आ सकता है ना?
Yes, sir. बिल्कुल.
ओके.
Let's take him time.
नहीं, फ्रस्ट्रेशन है ना यार, आदमी को रेडी रहना चाहिए, सर्जन है आप लोग यार। जो तब तक नहीं करते थे, मैं एक छोटा सा कहानी दे सुनाता हूँ।
Yes, sir.
महाराष्ट्र में शिवाजी, छत्रपति शिवाजी महाराज के धर्मगुरु रामदास जी थे। वो कोल्हापुर के आसपास घूम रहे थे, बड़ी कड़ाके की धूप थी, तो बरगद के पेड़ के नीचे बोले विश्राम करते हैं भोजन करके, और रामदास जी सो गए। अब उनके चेले सामने देखा, बहुत बड़े गन्ने के खेत थे, अंदर गए, मस्ती किए, खाए कम, तोड़ा है बहुत कुछ। उसमें से एक सीनियर फार्मर आया, इसके पीछे भागा, तो वो आके गुरुजी के पीछे छुप गए। उतने में हंगामे से रामदास जी की आवाज, आंख खुल गई, दोनों ने चार आंख से कुछ बात की, और वो बुड्ढे ने रामदास जी को एक फटाक से एक चपाट लगा दी। आर यू रेडी बालंदे? ओके, तो गुरुजी ने बोला भाई तुम्हारा नाम और वो गांव का नाम लिखकर उसमें डाल दो। बोले मुझे लिखना नहीं आता। तो शिष्य को बोला, उसने चिट्ठी में लिखकर डाल दिया।
Sir, सुनाई
और
दे रहा है?
गुरुजी,
Hello?
यस, या,
Am I
आर यू
not-
रेडी?
Yeah, sir. No problem.
ओके, ट्राई इट योरसेल्फ।
Sure. Sure.
मैं चाहता हूं कि भगवान धन्वंतरी और सरस्वती तेरे को यश दे बेटा।
My screen shared है already.
हाँ, स्क्रीन शेयर है, आपकी आवाज भी आती है, आगे मूव
ठीक।
करो उसको।
Now it's audible now.
यस,
Am I audible?
एक्सेलेंट ऑडियोबल। सभी
Sorry.
डिस्टर्बेंस हट गई है। वो तुम्हारा मॉनिटर का आवाज, कोटरी का आवाज सब चला गया।
Sorry. अच्छा, thank you.
आईसीयू में था ऐसा लगता था हमको यार। सर्जन को ऐसा नहीं करना चाहिए। चल फटाफट शुरू कर दिख रहा।
वहीं से ही आ रहा हूँ, आईसीयू से ही आ रहा हूँ अभी बाहर।
हाँ, पर तो वो तेरी हार्ट बीट में आईसीयू की आवाज थी, वही आ रही थी।
नहीं एक्चुअली
अच्छा चल चल, जल्दी कर, टाइम वेस्ट कर रहा है। गुरुजी बैठे हैं बड़े बड़े।
सर एक्चुअली
मेरे गुरुजी बैठे हैं वहां पे।
सर गुड इवनिंग, my nearest and dearest mentor Dr. Banigol sir and all my respected senior dignitaries on the platform. I'm very much thankful to the seniors for giving me this opportunity. I'm very small to speak on this international platform, but truly speaking, Sushruta as an endoscopist, it's a 15 minutes time is very low, very much less. But Sushruta as an endoscopist, he was a practitioner, he was a very good endoscopist. So only he has written a very good stanza, a very good sloka on the Nadi Yantras. Sushruta was an advanced endoscopist. Hello, am I audible, sir?
Yes, sir.
Sushruta was an advanced endoscopist. Not only he was not just an advanced endoscopist, he was an advanced endoscopist. He was pioneer that time, and now a mentor to all the GI surgeons, endoscopists throughout the world. He was a pioneer then. I repeat, he was a pioneer then and a mentor now. He is a guru to everybody, all the GI surgeons, all the GI endoscopists, and including modern surgeons and Ayurvedic surgeons. So Sushruta was the most practical, practiced person, and this is my unit where I do endoscopy procedures. So basically, let us get
Well,
into the
Andrew, your slide is not moving.
Sir, it's moving now.
But we are seeing only Sushruta as an endoscopist. Everybody is okay? Am I right or wrong? कोई बता सकता है? अजीत देख तो।
नहीं, सिर्फ स्लाइड स्टॉप है।
स्टॉप है।
आपका सब्जेक्ट ये, आगे कुछ स्लाइड मूव नहीं हो रही है आपकी तरफ से।
अभी
नहीं, वो पहले तो वो जो टप है वो उसमें से निकाल दे, उसको क्लियर कर, फिर जब तू करेगा तो ही सेकंड होगी, नहीं तो नहीं होगी। ये एडिट में है तू, अभी स्लाइड एडिट में है तू।
नहीं सर,
उससे पहले बाहर निकल। पवन एक प्रोग्राम रख, इन लोगों को कैसे बोलना, कैसे करना, उसके लिए टेक्नोलॉजी सिखाने। हो रहा है, वेरी नाइस। चलिए गो फॉर थर्ड, तुम्हारा यूनिट दिखाओ।
हाँ, यस।
सेकंड, थर्ड, यस, एक्सेलेंट, यू गो अहेड।
This is me and my assistant doing this procedure. And endoscopy is an advanced extended version of our Sushruta Acharya's Nadi Yantra. Its utility is as exactly as described with the Sushruta Acharyas for research purpose, to check efficacy of Ayurvedic medicines as a part of evidence-based medicines. These scopy and scopes are the diagnostic procedures are required in the field of Ayurveda for surgical management and limitations and extension of the disease, limitations for the surgeons and extension of the disease to understand, and the surgery and the probable complications if you proceed with the procedure. So we can understand with this endoscopy what is the Sushruta's concept of Nadi Yantra. He has told very good sloka on this Nadi Yantra, and basically I understand as endoscopy is an Nadi Yantra, and he has every word in this sloka are practically applicable. Nadi Yantrani, Aneka Prakarani, Aneka Prayojanani, Ekato Mukani, Ubayato Mukani cha. तानि स्रोतोगत शल्योद्धरणार्थम, रोगदर्शनार्थम, आचूषणार्थम, क्रिया सौकर्यार्थम. Every word has meaning, very good meaning. So simple, nadi yantrani aneka prakara. Yes, multiple types of endoscopes are available now. Upper gyroscopes, rectoscope, sigmoidoscope. Rectoscope is everybody's, especially Ayurvedic surgeons, bread and butter now. Hello, am I audible, sir? Hello?
Yes, yes, you are audible.
Everything
Sir.
is good now. Now don't check yourself. You go ahead.
Okay, sir.
If there is any obstruction, we will come back to you with MRI.
Thank you, thank you, thank you, thank you. And everybody, every Ayurvedic surgeon's bread and butter is rectoscope, sigmoidoscope, and colonoscopes. Majority of the people do practice nowadays. And ERCP scopes, EUS scopes, bronchoscopes, cystoscope, ureteroscopes, hysteroscopes, and there are so many scopes. Even spine surgeries they are doing under endoscope now. Even spine IVDP and laminectomies they are doing nowadays with the endoscope. So Sushruta was, he knew that we people are do all these things. And newer modalities in the GI endoscopes is the single balloon endoscopes, double balloon endoscopes, narrowband imaging, capsule endoscopy, fistuloscopes, spy camera, baby scopes, cholangioscope. These are the new modalities. So only he has told aneka prakarani, aneka prayojanani. So only aneka prayojanani. What and all we do with the endoscope? We do a diagnostic approach. To stop the bleeding, we use endoscopy. To take the biopsy, we use endoscopy. To retrieve the foreign body from the GI, we use the endoscopes. To understand GI fistula natures, tracheoesophageal fistula natures, we all to understand that we do the endoscopy. To check stent's position and displacement. So for a malignant cases, for a stricture cases, we put a stents, either SEMS or just silicone stents. How many stents we use? To cross check whether they are in a position or displaced, something we check. Structure dilatations, we use the endoscope. Endoscopic submucosal dissections, we use endoscope. And nowadays, this the very latest is the third space endoscopy. Nowadays, the therapeutic endoscopy we are doing. All these procedures are aneka prayojanani. That is the part of aneka prayojanani is this many of varieties we can use with the endoscope. And thing is ekato mukani ubhayato mukani. See, that time that ekachidra dvichidra some arshayantra ekamukani dvimukani, some explanations are available. But nowadays we need to understand single opening or multiple opening channels. So because you have to have a two openings, because one is patient and one more is a eye end. So single opening or multiple openings for our channels. And nowadays majorly multiple channels are available for the video endoscope. Fiber optic endoscopes usually used to bypass channel 1 and one more is air water channel. Only two channels used to be there, but nowadays we have multiple channels. Air water channels is to push the air to distend the stomach and the intestines. To see the view, to enhance the view, we use the air. And sometimes if the camera is being obscured by or smeared by some contents, camera clarity will go down. So that time we use the water jets to clean the camera, the lenses of the scope. These are the regularly we all the scopes we use this. And biopsy channel is extra channel which we use in every scope where these things are available. But nowadays, to pass the scope inside the scope, see, one we are using the one scope, upper GI scope or some lower GI scope, and we can pass one more scope through the channel of the main mother scope. So that's called as baby scope. So these which are available nowadays, we are doing the cholangioscopy with the baby scope. That is with the ERCP scope is there, and on top we pass the one more scope, that is the baby scope, where we can study all the CBD, common bile duct, this thing, common hepatic duct, and everything. These things can be studied, and we can take a biopsies or the polypectomy can be done through these scopes. Okay, Shrotogata Shalyodharanartham. What is this Shrotogata? There are so many, some kids or some psychiatric patients, they swallow some foreign materials. Some kids usually swallow coins or pins or something. And there is a record of removing foreign bodies. There are one of my friend who is from Sangli who has removed 54 total foreign materials. Among them, 20 was the toothbrushes. That is the depression patient. So this much of things can be removed from the scope. Just imagine how it is helpful. Just imagine you cannot open whole abdomen to remove all these 20 toothbrushes and other 34 other objects. So this is how it is useful. This is how it saves the life. This is how you can save the major procedure, and where it's a life saving. To remove CBD stones nowadays, earlier people used to open for CBD stones, but nowadays we do the ERCP, and if the bigger stones are there, we crush and we remove, because sometimes there are very much possibilities. Sometimes they go and get stuck in the ileocecal junctions. So patient may develop CBD stone induced intestinal obstructions. So to avoid that, nowadays we retrieve the CBD stones also. And sometimes after ERCP, we keep a pigtail stent to keep the CBD open for a long time, so that it should not risk fibrosis, it should not get a stenosis. So to avoid that, we keep the pigtail stent for at least 6 weeks. Then we remove after 6 weeks. So we remove with the upper GI scope only. So retrieve the stents after ERCP, and you can reposition the stent stems or something in the malignant cases. If it is displacing something, we can fix it. All these are possible with the Shrotogata Shalyodharanartham. Droga Darshanartham. Diagnostic aspects, basically direct vision of the disease and the lesions. You can take it, whether it is a malignant, benign, or bleeding, or elevated, or undule, or all these things can be seen. For example, snake skin scaly appearance we see in snake skin means like a snake, how the snake looks. The same way, if there is a portal hypertensive gastropathy is there, we can see that. We can either take a biopsy, nor we can do anything. But only the vision will tell you that the liver is not healthy. Only with the upper GI scope, if there is a snake skin appearance is there in the gastric mucosa, you can see that liver is involved. So this is the Roga Darshanartham. This is something like Aptopadesha in the Padartha Vijnana. Achushanartham. So Achushanartham, with what vision Sushruta has told Achushanartham, we don't know. But what exactly we are using the endoscope in nowadays current practices? Suction, we can use the stomach content, gastric. Sometimes unprepared patient comes with even though we tell the patient to not to have anything, but patient used to have some liquid contents or something they'll have. Then they come. Then when we put the scope, then when we go and reach the stomach, that time only we'll come to know that patient has swallowed something. So that time there is no alternative go. So that time we suck and remove the stomach contents, and then we examine further. In the same way in colon also, even though we try to prepare the patient for colonoscopy, sometimes there will be the liquid contents will be there in the colon. So that time we suck and remove we see all the GI or the colon or the stomach. We suck and we check it, and especially therapeutic suction nowadays. This is the present decade. Majority of the nowadays gastroenterologists are doing pseudopancreatic cysts, with chronic pancreatitis. Those who have complications of chronic pancreatitis is the pseudopancreatic cysts. They are being drained through the gastroscope, and they put a scope when the majority of the elevation, there is a dependent part or not dominant part. On the dominant part, we open through the scope. We can use the cautery through the scope. We cut the gastric posterior wall, and we open through the pseudopancreatic cyst, and then we drain out all the contents. Even we can debride, we can give the wash to the pseudopancreatic cyst. We can whatever the debris can also be removed through the scope. So this is the Achushanartham is very practically nowadays we are using. And Kriya Saukaryartham. See, it's not the main procedure. It is Kriya Saukaryartham. to help for the major procedure, to help for the main procedure, whatever intended for that possibility. We can understand that either biopsy, taking the biopsy, to place marker in esophageal balloon dilatation. For example, if there is distal esophageal or any esophageal stricture is there, we do a balloon dilatation. And for example, for in achalasia cardia, we do the balloon dilatation. And Sanks taken Blackmore dilatation, where we use for the esophageal dilatation. That time we keep one major marker. We keep a metal marker through the endoscope at the level we can measure, and we put the marker there. It helps for a dilatation, balloon dilatation in direct vision and the C-arm guided also. We can use both C-arm and endoscope both at a time, so that the endoscopes help you to keep the marker. And to place the trocar, to place the feeding gastrostomy tube. For example, the patient has underwent a CA esophagus surgery or some small intestinal malignant. If there is any CA esophagus, majorly CA esophagus is there, we place the directly feeding tube to the stomach or the jejunum, jejunal gastric, feeding jejunostomy or feeding gastrostomy do. To place the trocar, to fix the tube, we use the endoscope. And to place the hemostatic clips in GI bleeding, it's a direct, it is later will come down to why it is bleeding, from where it is bleeding, that is, and whether what is the liver condition, what is other things, later we can think. But at present, we put the hemostatic clips and stop the bleeding. And we inject glue, that is the glue or the sclerosants is the earlier things. The majority of the people earlier gastroenterologists use the sclerosant agents, but nowadays people are using glue, that is directly into the esophageal varices, directly into the veins only they inject the glue under vision. You can see the vein varices, you can see under vision. You can put the glue into the vein only. Within the 2 seconds, it will bulge and stop the bleeding. So this is the Kriya Saukaryartham. Endoscope doesn't inject the glue, but the injecting through the glue, through the scope is possible. So only Kriya Saukaryartham. It helps other procedures. It helps some another gadgets can do better. Other gadgets can do better performance through the endoscope. So this is how you need to understand Kriya Saukaryartham. And the next is Sroto Dwara Parinahani Yatha Yoga Dirghani. See, just imagine the wisdom of the Sushruta. Sroto Dwara Parinahani. Nadiyantras is very common sense that according to orifice, you need to have the circumference of the scope. And Yatha Yoga Dirghani depends on how much you want to examine, that much length should be the endoscope. That much length should be the Nadiyantra. So the endoscope circumference and length of the scopes always depends on the orifice and the area to examine. And the smallest one available in the world is cholangioscope, that is up to 4 to 5 mm, and pediatric scopes, that's up to 8 mm, upper GI scope up to 1 cm 10 mm, ARCP scope up to 15 mm, and colonoscope it's up to 15 mm. So these are all the variety of the circumference keeps on increasing till the colonoscope, and the length keeps on increasing till the colonoscope. This cholangioscope is long, but not more longer than the colonoscope. So these are the varieties of Sroto Dwara Parinahani. See, without a practice, nobody can write like this. Sroto Dwara Parinahani Yatha Yoga Dirghani. Every word in this sloka is practically applicable, and he has practiced it. So only Sushruta was a pioneer in endoscopy at that time, and now he is a mentor. So, and he on top, he has given at the end, Swabuddhya acha vibhajet yantra karmani buddhiman. Because by using your intellectuality, you can use multiple permutations, combinations with the yantras. Sandhya vikalpat means multiple things, unlimited, infinity. So he has told, use your brain and you do accordingly. Not only he has told, whatever he has told, you need not have to use. Use your swabuddhi, use your own intellectuality and proceed further. He has not. He has given you the open option, open permission to do all the possible this thing permutations and combination to improve the instruments and the surgical skills. So, and what the pre-endoscopic preparations, what we do is keep the patient nil orally, nil by mouth, rule out patient whether diabetic, hypertension, or IHD or COPD. Precautions with the thyroid drugs. Never stop for thyroid drugs even on the day of endoscopy. At least ask 6 hours prior to the scopy. You ask them with 1 or 2 teaspoon of water. You can have the thyroid drugs. Remove dentures. Rule out sensitivity of lignocaine. Sometimes in my lifetime, I have only one case who is sensitive to the lignocaine. I had to permit the procedure. So you have to rule out the sensitivity. Very commonly, majority of the surgeons go without any sensitivity test. Should always go with the sensitivity test and always do with the consent of the patient and patient relatives, because they are the paying people. You'll have to take a consent of them also. It's okay. So pre-endoscopy, properly disinfect the scope, and scope should be properly disinfected, because the same scope we use for everyone. So you cannot use it. You cannot do this use and throw scope. So this proper disinfected with the formal glutaraldehyde or citraldehyde. You can use this. This is what is that? Sidex solutions or something they use. Everybody we are using this. Give lignocaine viscous for gurgling or surface anesthesia. With nowadays 10% lignocaine spray is available. We use that. So that is very in a short acting, and it's very easy nowadays, because this viscous will they'll start feeling nausea or something. So it's best is surface anesthesia with a 10% spray, and counsel or educate the patient what you are doing with him and what is the cooperation you require from his side and what you are going to do with him. If you educate them, patient majority of the people will cooperate you and they'll undergo the procedure. Patient's cooperation is the prime important. Without the patient's cooperation, you cannot do anything. Though whatever may be the gold medalist, you are in an endoscopy, but without patient's cooperation, you cannot do anything to the patient. So this is the normal pharynx and vocal cords, and this is the normal pharynx. Just 1 or 2 videos, just to finish the thing, because if you start having videos of all other lesions of the endoscopy, I need to have at least 2 to 3 hours. So these are the pinnate ligament. I'll have this is the larynx, and there are 2 vocal cords and false vocal cords. This is the piriform fossa where my scope is getting in, and now I am in upper esophagus. Now I'm going, keep always scope in the center. Now I am heading towards the lower esophagus. This is the G junction or Z junction. My scope directly get into the stomach, where you can see the lesser curvature. You can see the lesser curvature and greater curvature down. Now you can see there is a hole, a circumferential opening here. That is the antrum. That is the pylorus, which is antrum. Circumferential opening is the pylorus. And now the pylorus, through the pylorus, we need to negotiate your scope. Negotiate your scope to the duodenum first, where you can see the turkey towel like mucosal appearance, mucosal lining appearance. This is the second part of the duodenum, where transverse mucosal folds are there. And now my scope is coming back. Now it is in the antrum. I'll just J view, J maneuver, we call it as a J maneuver. Just retroplex the scope. You can see the fundus. This is the liver impression. There's a dome like this, the liver impression. And coming back, this is for a trial. This is right upper one at 1 o'clock is the lesser curvature. We're coming back and once again reviewing with the G junction. Is there any lesion? Here it's not properly closing. You can see the cardiac impression here and cranial impression at the upper one. Now I'll come back. I can always examine vocal cords before going out of the mouth. Before removing the scope, you should always go for this is just a difference. This is there is a left piriform penis flow. There is a sinus growth is there. So vocal cords movements are also, I'm taking a biopsy here, left, even vocal cord movements are also hampered. Here you see the difficulty in deglutition, voice changes there, and everything. This is the tenting, what is called as the tenting of the mucosa. It looks like more of benign lesion. If it is a tenting, it is benign. If it is coming with the cuts immediately, means it is a malignant. So always, and these are all for just a small, these two videos for just a reference of this thing. I have put them. And always an endoscopist should understand the indications, why he is doing an endoscopy, what are the indications, and what are the contraindications, what are the alternative procedures. If you cannot perform the endoscopy, means what is the alternative procedure, you should understand, you should know always. And always endoscopy should interpret the things correctly, because since somebody don't know the anything about the endoscopy, it doesn't mean that you can write anything and send him. Should interpret the findings correctly, and it should always match with the clinical complaints. Perform the procedure proficiently. You should always professionally behave with the patient. Do all the gadgets should be in a good condition and safely. Always integrate the findings into therapy or management plans. If somebody has referred you, for example, one of our colleagues has referred you, you do endoscopy and don't do the manual job, and integrate the findings and just convey the same thing with the co-practitioner, that what might be the next thing, what best can be done, so that you can help the patient. And always endoscopists should avoid and recognize and manage the complication on table. Avoid the complication. First, you should avoid the complication. If at all something goes wrong, you should recognize where it's going wrong. If at all it has went wrong, know the management of the complication. So you should know. If you don't know anything about these things, don't do the endoscopy. Assess pre-procedural. Before the procedure, you should assess the patient and plan the post-procedural. After the procedure, you should plan, follow up, everything. Post-procedural follow-up you should know all these things. The take-home message is all acid peptic disease cases are better to be evaluated with endoscopy. While treating the patient, lifestyle changes are to be given more importance. Only medicines, A churna, O churna, this tablet, that tablet, only prescribing, more than the prescribing, you should spend some time with the patient. What are the wrong habits they have? Ask them to change the lifestyle. Then only your treatment will work and you will have a good name in the society. Otherwise, if you prescribe directly after doing endoscopy, probably 50% of the patients won't relieve with their symptoms. So always ask their lifestyle changes. Ask if there is any problem in their lifestyle, you should educate them. Depending on the cases, herbal, Kharaushadhis, herbomineral, Rasaushadhis, and medicines can be used. Other investigations like EUS, USG, CT, MRI can be done as and when required based on the cases. Nowadays, virtual endoscopy with the CT is available. If the patient you cannot do an endoscopy, you can go for the virtual endoscopy with the CT. This is available nowadays. So always the questions are guaranteed in life, answers are not. Why these questions come? Whether majority of the audience will have this question, whether Ayurvedic surgeons can do these things, whether they are allowed, whether they are legally allowed, whether they can perform this diagnostic only, whether they can do the only even they can extend their therapeutic procedures also. All these questions you have. For all the questions, you do not have to have all comfortable answers. But without trying, you cannot find the answers. So I am trying, and before me there are 4-5 surgeons have already trained. They are succeeded. Even now I am also succeeding. So for all these questions, smile is the only curve which puts everything straight. Keep smiling, keep practicing, keep proceeding through the scope, do the advanced things. Then only we will be recognized by the practitioners, by the patients, by our scientific committees also. This is my experience. Thank you all, Sushrutas. this is happy to involved in the SUSHRUTA Jayanti and programs. I am very happy, thankful to the organizers. If there are any questions, please you are open to ask. And if there are any feedbacks, please mail me on this mail.
Barendra, please wait for 20 minutes because Ajit has to finish and then question answer will be start.
Okay, sir.
Wait for 20 minutes, beta, please. Ajit Khalkar.
Yes, sir.
Can you stop the sharing, Barendra, please?
Sure, sir. 100%.
Yes,
This
sir.
is yours. I again beg pardon about your title, but you can go ahead with a very unique. You have found some unusual benign tumors and how you have handled. Please share with us. Thank you very much. Ajit Khalkar is a very good practitioner and he's been very academician. I know him couples of the years and we was at together at Cairo, and this presentation he is present over there. It was been well accepted by the Western countries. Thank you very much, Ajit. This is your turn.
Desktop.
You can show them.
Yes, good evening all of you. I am grateful to the organizers of AYUSH SAMRIDDHI, this SUSHRUTA Jayanti's international webinar. I am grateful to my Sangvi sir to give me opportunity to deliver a small talk on the special case, that is the rare case of perianal epidermoid cyst. The great Sushrutacharya had given a message with Ashtavidha Shastra Karma. And what I am saying that there is no surgery in the world without Chedan, Vedan, Vedhan, Lekhan, Eshan, Aharan, Visravan, and Sivan Karma. These are the Ashtavidha Shastra Karma, what Sushrutacharya has taught us. And most of the Shastra Karma are included in this my case, that this is what we are calling granthis, and what I found in my surgical practice I am sharing with you. Epidermis is found mostly commonly on face, neck and trunk. They are very rarely found in the perianal region, and they are growing as most of the benign lesions originate from the epidermal layer of the skin. There was a patient of 26 years old, male patient, presented with a right anterior perianal swelling with pain, discomfort since 1 month. Patient noticed perianal swelling since last 1 year without pain. Recent history was with mild fever and chills. Before approaching us, the patient visited 2 more our colleagues with no clinically perianal pathology they found. Blood reports were normal, except WBCs were higher side, 11,400. Assuming primary diagnosis as a perianal abscess, the case was posted for incision and drainage under the spinal anesthesia. No radiological investigations were done as unavailability of these resources and at that time. And what we clinically found that it might be the perianal abscess, simple case that we could do the incision and drainage. That is Chedan and Vedan. After giving an incision, the chasey keratinous material comes out through the wound. what you can see, I have done the Chedan karma first, then Bhedan with the help of artery forceps, Vedan. And this was not obviously the pus, what we were expecting from this case, but the sebaceous type of material was coming. And this was the very first case in my 23 years of practice, what I was facing in the operation theater. Now, what we are doing, Asian, Lekhan with the help of scoop and Aharan also. See, I am scooping out the disease material, all the sebum with foul smell, Vishravan by pressing around the tissue. And here I have given the incision perianal circumferentially, what Sushruta Acharya has given the Chandrakar, Ardha Chandrakar linear incisions stated in the Sushruta Samhita. This is the cyst wall, what I am excising here. Blunt dissection is going on, and I have removed the complete cyst wall, which was the culprit. Here, the incision was not so much of bigger because I had scooped out the material and the cyst becomes smaller, so that I was able to remove that cyst with the incision of just only 1 inch size. The cyst was almost big was almost as to tennis ball size, near about 8 by 6 by 5 centimeters. And the only last Shastra Karma, Sivan Karma, I had omitted in this case because of any foreign material or that sebum material could infect the wound, so that I have omitted the Sivan Karma. This was the on-table picture, same day. This was the post-operative second day, and patient was discharged without pain. This is the post-operative 1 month picture. The wound healed completely within 3 weeks span. This was the histopathological image of the same patient of the slide. And this is the histopathology report. I am thankful to Dr. Manohar Jadhav, our pathologist. These are the references papers. So after facing this case, I've gone through the study papers. There were very limited cases what I could found on internet. See the bigger one, and almost 10 papers I could found on internet. These are the references what I found. I am sharing with you. And again, we are thankful to the Sushruta Acharya that in the world there is no one any surgery without this Ashtavidha Shastra Karma, and we are proud of him. What was the conclusion? What I faced in operation theater, that we all surgeons must do the investigations prior the case. The differential diagnosis of the cystic lesion in the perianal region include abscess, tail gut cysts, anal glut, duct gland cyst, pilonidal cyst, benign teratomas, or cancer, maybe other things. Perianal swellings should be investigated radiologically prior to the surgery and should also be considered as perianal epidermoid cysts. Thank you. Thank you,
Thank
sir.
you very much, Ajit. Thank you very much.
Yes, sir.
तीनों ने बहुत अच्छा प्रेजेंटेशन किया। कल के जैसे ही मैं कहता हूं कि भाई माँ बाप को अपने बच्चों की तारीफ नहीं करनी चाहिए, समाज को करनी चाहिए। वासने सर को सबसे पहले मैं निमंत्रित करता हूं सर, सुभाष चंद्र वासने जी।
वाह क्या बात है। हेलो हेलो,
यू आर लाउडली क्लियर सर, आप दिख भी रहे हैं। अजीत, स्टॉप योर स्क्रीन शेयरिंग बेटा।
Yes, sir. Yes, sir. Thank you.
Thank you. Stop your face also. Thank you. Mute yourself.
So I congratulate to Dr. Ajit for delivering a very nice talk upon the perianal cyst. और ये आयुर्वेद में बताया गया रोगम आदौ परीक्षेत, तो पहले रोग की परीक्षा तो करनी चाहिए। मैं उनकी बात से सहमत हूँ। कोई भी अगर ऐसी चीज है तो उसको ढंग से पहले आप निदान करिए, उसके बाद ही आगे बढ़िए चिकित्सा के लिए। और बहुत अच्छा केस उन्होंने प्रेजेंट किया, उनको बहुत बधाई इस बात के लिए। दूसरा जो सुश्रुता नाड़ी यंत्र के बारे में जो प्रेजेंटेशन था, तो उसमें जैसे सुश्रुता ने क्लियर बताया नाड़ी यंत्र के प्रकारों में या चिकित्सा उसमें जो है कि भाई रोग दर्शनार्थम, आचूषणार्थम, क्रिया सौकर्यार्थम और स्रोतोगत शल्योधनार्थम, ये चारों चीज जब कोई लेप्रोस्कोपिक सर्जन लेप्रोस्कोपी करता है या फिर एंडोस्कोपी करता है, तो ये सब सिद्धांत जो सुश्रुता हजारों साल पहले बताए हैं वो आज भी उतने ही सत्य हैं। चाहे वो इंस्ट्रूमेंट की जो डिवाइस हो गए अलग अलग टेक्निक, लेकिन टेक्निक वही है और उससे हम वही अचीवमेंट करते हैं। ये चारों चीजें ही अचीव करते हैं। और जो आपको जैसे उन्होंने वोकल कॉर्ड वगैरह जो बहुत अच्छा दिखाया, ये आयुर्वेद के लिए अच्छा डेवलपमेंट है। तो इंडिया में आयुर्वेद के लेप्रोस्कोपी सर्जन बहुत अच्छे डेवलप हो रहे हैं। मेरे ख्याल से सुश्रुत नाड़ी यंत्र के ऊपर डॉक्टर रमन सिंह की पहली थीसिस है और वो बहुत अच्छे बनारस के लेप्रोस्कोपिक सर्जन जाने जाते हैं और बहुत अच्छा काम आयुर्वेदिक लोग कर रहे हैं इस क्षेत्र में भी, और मैं सभी को इस बारे में बधाई देता हूँ। डॉक्टर बन्नी गोल ने जो बहुत अच्छा प्रेजेंटेशन दिया, मैं समझता हूँ 2 पेपर को मिला दिया एक पेपर में। सिरावेद अलग रख सकते थे और ये एक अलग रख सकते थे। बहुत अच्छा, वो सीनियर आदमी है और बहुत अच्छा उनका जो था प्रेजेंटेशन बहुत ही अच्छा था। जहाँ सरंग जलों का अलाबू, जहाँ दोषों के साथ वर्णन किए गए वहाँ ये भी बताया गया है प्राय सर्वे सर्वा, तीनों का उपयोग आवश्यकता के हिसाब से आप कहीं भी कर सकते हैं। ऐसा कुछ नहीं है कि भाई दोष के हिसाब से ही करें, आप कहीं भी किसी का उपयोग कर सकते हैं। और जहां तक लीच के बारे में बताया है तो सद्यो राग रुजा समा, तो इमीडिएट पेन और रेडनेस एकदम ठीक हो जाती है। इसमें जो सुश्रुत ने वचन दिए हैं वो बिल्कुल सही है। थ्रम्बोज पाइल में अगर कोई टेबल पर रिजल्ट देखना चाहे लीच एप्लीकेशन का तो वो वाले आराम से देख सकता है, इमीडिएट रिलीफ मिलता है। और मेरे ऐसे कई थीसिस हो चुकी है मेरे अंडर में इस बारे में और बहुत ही अच्छा इसके रिजल्ट्स हैं। थ्रम्बोज पाइल्स में, इन्फ्लेम्ड पाइल्स में बहुत ही अच्छे रिजल्ट्स हैं। और इसके अलावा हर्पीज में भी बहुत अच्छे रिजल्ट हैं, ट्राइजेमिनल न्यूरोलजिया में बहुत अच्छे रिजल्ट हैं। तो जहां जहां पेन है, जहां जहां लालिमा है, वहां लीच अपना प्रभाव दिखाती है। और क्यों दिखाती है वो उन्होंने बताया, बिकॉज इट कंटेन लॉट ऑफ थेरापेटिक जो है एल्कलॉइड्स एंड सम ऑफ, तो हर एक की अपनी अपनी वो है। और अभी रिसेंटली मेरी स्टूडेंट ने जैसे काम किया तो उसमें ये पाया गया कि भाई जो लीच एप्लीकेशन के बाद जो है सी रिएक्टिव प्रोटीन एस्टिमेशन करते हैं और लीच एप्लीकेशन से सी रिएक्टिव प्रोटीन कम होती है, तो ये अगेन प्रूफ है कि भाई ये इन्फ्लेमेशन को कम करता है। तो मैं समझता हूँ, बहुत ज्यादा मैं समय नहीं लूंगा, बहुत समय हो चुका है ऑलरेडी। तो बहुत अच्छा तीनों प्रेजेंटेशन रहे और आप सबको बधाई इस बारे में। सुश्रुत जी आज के बारे में हम लोग याद कर रहे हैं, वास्तव में बहुत ही, ये संघवी साहब बोलते ही हैं कि भाई धन्वंतरी भाग अदा करिए, तो वास्तव में हम लोगों की ड्यूटी है धन्वंतरी भाग अदा करने की, उनकी याद करने के लिए। और बहुत बहुत धन्यवाद आप सभी का, बहुत बहुत धन्यवाद। थैंक यू वेरी मच।
गुरुजी प्रणाम सर, प्रणाम। Anybody want to have some questions or some suggestions about this one by one 3 presentations? Anyone? Mic over to the Agnihotri sir.
थैंक यू सर, थैंक यू प्रोफेसर महेश सिंघवी सर, बड़ा अच्छा लगा। आज प्रोफेसर सुभाष वार्ष्णेय जी हम लोग के साथ जुड़े रहते हैं, ये हम लोग के लिए बहुत ही बड़ा मॉरल बूस्टिंग की बात रहती है, स्पेशली इतना इंटरेस्ट लेके सुनते हैं सभी को और उन पर एक अपनी विशेष टिप्पणी भी देते हैं। अच्छा लगा, बल्कि मजेदारी बात ये आई कि उन्होंने डॉक्टर रमन सिंह का नाम लिया, वो हमारे 80-83 बैच में हमारे साथ थे और वो मालूम है अच्छी प्रैक्टिस कर रहे हैं वहां पर, ये उनका याद आ गई।
अग्निहोत्री सर आप म्यूट हो गए।
सर आपका आवाज नहीं आ रही है, म्यूट हो गए।
अनम्यूट हो गया था। बाकी आज के तीनों ही अतिथि वक्ताओं को, सर्जन्स को हम बहुत बहुत आभार भी व्यक्त करते हैं, बधाई देते हैं। और शेष में आप लोगों के सामने तो केवल इतना ही कह पाएंगे कि तत्र धन्वंत्याणाम अधिकार क्रिया विधौ, तो उस क्रम में तो आप लोग ही सशक्त हैं और इनके प्रेजेंटेशन को अच्छे से परिपूर्णता की ओर ले जाते हैं। और इतनी लंबी प्रैक्टिस, 20 साल से ये लोग इतना बढ़िया काम कर रहे हैं, चिंता सेवा कर रहे हैं, उधर नासिक में कर रहे हैं, वहाँ कर रहे हैं, मुंबई में, तो अच्छा प्रेजेंटेशन रहा। और इतनी देर तक जुड़ते हुए हमारे साथ प्रोफेसर वार्ष्णेय जी रहे, इसकी बड़ी हमें खुशी है। और हमारी प्रथम सत्र यानी वेबिनार में भी डॉक्टर प्रोफेसर ई शर्मा साहब मॉरिशस से जुड़े थे, हम उनका वेलकम अब करते हैं, उस समय नहीं कर पाए क्योंकि लगातार दूसरी बारी वेबिनार शुरू करनी थी, तो अच्छा लगा। और किन्हीं की कोई एड ऑन करना है, टीका टिप्पणी, कुछ सजेशन देना है तो स्वागत है, क्योंकि हमारे इस समय प्लेटफॉर्म पर हम सब मिला के 12-13 लोग हो रहे हैं और विद्वानों ने अपनी स्थिति दे ही दी है।
मैं एनेस्थेटिक साहब का और श्रीराम जी का वक्तव्य सुनना चाहता हूँ, खास करके एनेस्थेटिक सर है कि नहीं?
शैलेश जी तो अभी शायद नहीं जुड़े हैं।
अच्छा,
शैलेश जी हमारे नहीं जुड़े हैं, वैद्य श्रीराम जी जुड़े हुए हैं, क्योंकि वो तो 9 बजे
वो कुछ कहना चाहते हैं।
आइए वैद्य जी, स्वागत है आपका, आपका आमंत्रण है। आप आज के प्रस्तुतियों पर कुछ अपना मंतव्य देना चाहेंगे तो आपका स्वागत है। नमस्कार।
गुरुजी अनम्यूट करें अपने आप को।
हाँ जी।
Malendu, I request you to call me tomorrow or late night after finish this.
Sure, sir.
हेलो सर।
हाँ गुरुजी।
हाँ सर, आलोक बोल रहा हूँ सर।
हाँ आलोक, yes, I forget you would like to share something?
हाँ नहीं सर, मुझे बेनेगल सर से क्वेश्चन था, सर है क्या कि लीव कर दिए, दिख रहे नहीं इसमें।
ठीक है, क्वेश्चन लिख दे, मैं भेज देता। तेरे पास नंबर है क्या नहीं सर का?
हाँ नहीं है सर, वही
भेजता हूँ अभी, मैं तेरे को व्हाट्सएप कर देता हूँ, व्हाट्सएप कर ले सर को।
ठीक है ना सर, ओके सर, थैंक यू।
क्या क्वेश्चन क्या था, हम भी तो जाने।
हाँ, वेरिकोज वेन में सर ने जैसा शिरावेद भी बताया, तो इन्हें जलों का चरण ज्यादा बेनिफिशियल है कि शिरावेद, और कौन से कंडीशन में शिरावेद करना चाहिए और कौन से कंडीशन में जलों का चरण करना चाहिए, वो पूछना था सर।
वेरिकोज वेन्स में यदि बिगिनिंग है और जैसे ये पेशेंट पर दिखाया था ऐसी गट्ठे बाहर नहीं आए हैं तो जलों का काम करती है, और अगर ऐसा है तो वहां पर शिरोवेद करना चाहिए। ये मोहन कुमार जी का डिस्कशन है और उसकी बेटी जो है उन्हीं का काम लेकर एक कल या परसों में आ रही है।
अच्छा सर, ठीक है ना सर।
मेरे को ये सिखाया था उन्होंने भुवनेश्वर में वर्कशॉप में, मैंने कभी नहीं किया था लेकिन मेरे हाथ से ही करवाया था। वो बोले कि चल तू कर। वहां पर एक पेशेंट लाए थे MM राव साहब, और हमारे पास कुछ नहीं था, एक बल्ब तोड़ा, उसमें से वो बनाई, फिर वो नीम की लकड़ी लाए, इनके ऊपर रबड़ बैंड बांधा, ये वहां पर टूर्निकेट नहीं था तो किसी की वो चुन्नी बांध दी, और वहां से कुछ जो है लेपालूपी करके मेरे से ही करवाया। बड़ा इतना डर था मेरे को कि जिनकी कोई सीमा नहीं थी। बोले कि फाड़ के रख देता है तो साला इसको क्या होएगा, टाका मार देंगे, तू कर, लेकिन यू कैन डू इट। और उस दिन से मैंने ये काम शुरू किया, बहुत साल हो गए। मैं आज भी गुरुजी का उसके लिए मैं प्रणाम करता हूँ, और उन्हीं का काम लेकर उसकी बेटी अपने पास आ रही है। So concept is clear, Alok?
हाँ सर, हाँ सर.
So where there is a cellular, you want to be, the evacuate. I think so. Balendra can also, or Ajit or anybody can, वासनी जी भी है शायद अभी तक तो जब कहीं पर भी कैपिलरीज और सेल्यूलाइट में से तुमको लेना है, तो you have to use leech, and when you want to be direct with the vein, सिरावेद जैसे सर गुरुजी सर ने बताया था, तो you should have to take a सिरावेद. Am I right, sir?
आपका जो अनुभव है वही मैं मानता हूँ कि मैं इससे
के हिसाब से बात कीजिए सर, मैं तो
लेकिन मेरा
मुझे
बिल्कुल
थियरी नहीं
विरोध है,
आती.
एकदम विरोध है. वेरिकोज वेन ये एनाटॉमिकल डिफेक्ट,
यस,
इट इज नॉट. तो कॉम्प्लिकेशन यदि है, थ्रोम्बोफ्लेबाइटिस है, या फिर यदि एक्जिमा हो गया है या अल्सर हो गया है, तब तो लीच एप्लीकेशन या सिरावेद का मैं समर्थक हूँ. अगर एनाटॉमिकल वाल्वुलर डिफेक्ट है तो मेरे ख्याल से अपनी दोनों पैथियां मेरे अपने हिसाब से नहीं है, लेकिन आप उसका प्रभाव दिखा रहे हैं तो मैं आपसे सहमत हूं कि भाई आप हो सकता है प्रभाव हो, लेकिन मेरी अपनी स्टडी में मैंने लीच भी एप्लीकेशन किया है, कोई वेरिकोज वेन ठीक नहीं होती है, उससे कॉम्प्लिकेशन ठीक होते हैं.
मैं आपके साथ सम्मत हूँ. ये तो बात ये थी कि लीच कहाँ लगाना, सिरावेद कहाँ करना. अब ये जो आप कह रहे हैं, मैं आपसे मानता हूँ सर, कई सिरावेद मैंने किए हैं, लेकिन किसी का भी वेरिकोज में ठीक नहीं कर पाया. आई एक्सेप्ट इट.
Sir, can I add some more things?
Yes, we are for that only. We are ready to learn from our juniors' experience.
Sir, especially in varicose veins or this thing, if there is any hemosiderin collection, this subcutaneous changes, color changes and inflammatory changes are very well reduced with the leeches. But as sir said, the valvular changes where the vessel thickening, wall thickening is there, that can never be repaired with this thing, Shiraveda. And whatever you make a tourniquet, and then you whatever the column loaded with the fresh blood you are removing, only the loaded column, when the loaded column is there, till you puncture the vein, whatever the venous pressure is there, that is the painful. Once you puncture the vein, all the venous wall loaded pressure will come down, patient will feel lighted, patient will feel that immediately feel painless something. After certainly after 2 hours or something, once again he is going to have the same symptoms. Unnecessary, you are wasting 125 ml of blood, fresh blood, without any cause, because it's not going to change any. Only the gravitational force which was acting on the wall of the veins, you have reduced by removing it by one bottom puncture. That's it. More than that, it's not going to help anything. Only thing, even minor degrees, when only skin changes, where the blackish discolorations, all these things will reduce with the leech. I believe the leech in the initial phase, next either a laser ablation or something, Mayer stripping or something are more helpful than this thing, Siraveda. I solely accept Varshney sir's words, and I hats off to him.
You are absolutely right. But at the time I have discussed with the Mohan Kumar when I was failure, I went to his, the hospitals, and he said that if you feel it, it will be burst anywhere, or otherwise it's create, the skin cellulitis. You should have to remove 50 to 100 ml. So the complication you can stop. Now you are absolutely right. Laser ablations with this sclerotherapy, and nowadays new material has come. This is a glue. It's from anterior to posterior and laser from posterior to anterior with the USG guided. I do not do, but I am assist to my surgeons in the hospital regularly. Thank you very much, your output. Thank you. Anybody else? Shriram Sharma ji shayad ready hai. Guruji. अग्निहोत्री साहब शायद आपका आवाज सुन ले.
हेलो.
यस, वी आर हियरिंग यू नाइसली सर. आपकी आवाज बहुत सुंदर है
सर. मैं बहुत कुछ अभी नहीं देख पाया, अभी थोड़ी देर पहले ही मैंने ज्वाइन किया है, इसलिए मैं कमेंट तो बहुत कुछ नहीं कर पाऊंगा. और लेकिन जब भी आपको समय मिले, मैं निवेदन किया था कि मेरे वीडियो का टाइम सिर्फ 3 मिनट का ही है, उसमें सारे वीडियो वो कभी टाइम दिखा दीजिए, फिर मैं बोलूंगा उसके ऊपर.
कल उसको दिखा देंगे सर। मैं आज थोड़ा लेट ज्वाइन हुआ, मेरी गलती है, लेकिन
ना,
मैं
ना।
कल आपको यकीनन बिगिनिंग में दिखा देंगे। कल आप ज्वाइन हो जाइए 9 सवा 9 बजे।
संघवी सर, आपकी कोई गलती नहीं है, आप बहुत अच्छे विद्वान हैं और मैं तो आपका सभी का सेवक हूँ, सभी का एक तरह से आदर करता हूँ। आपका संघवी साहब, आपका एक नंबर मेरे को सेंड कर दीजिए।
हाँ, मैं अभी आपको चैट बॉक्स में लिख के दे देता हूँ सर।
जी जी जी।
थैंक यू वेरी मच। अगर इफ नोबडी हैज एनीथिंग क्वेश्चन, सो वी गो फॉर द पूर्णाहुति। कल के जो 3 स्पीकर है उसके मैं नाम बता देता हूँ। वो तीनों जो है साउथ से है, आज भी 2 साउथ से थे। मेरा आज से पूर्णाहुति तक के सभी मेरे जो है लेक्चर मैंने कैंसिल कर दिए हैं। एंड आई वांट टू लिसन ऑल माय द जूनियर कलीग्स एंड लर्न फ्रॉम देम व्हाट यू आर गोइंग टू बी डू बेटर देन मी। सो कल के जो है मुरलीधर शर्मा जी हैं, वो उडुपी से है। डॉक्टर पटनायक सर है, वो बैंगलोर साइड से है। और विजय हल्ली ना बलेंद्रू
सर मैं भुवनेश्वर से हूँ, उड़ीसा
हाँ,
से।
सॉरी भुवनेश्वर, माय मिस्टेक, क्योंकि आपका वो मैंने उस समय बैंगलोर लिख दिया था,
हाँ
गलती है सर। भुवनेश्वर
उसमें
से
मिले
है।
थे। हाँ हाँ हाँ।
हाँ, तो और तीसरा जो है विजय हल्ली है, बराबर है बलेंद्रू?
हाँ सर, विजय हल्ली
हाँ, ये
इलकल का।
तीनों जो है कल, और हमारे सबसे जो है सीनियर मोस्ट एंड डेडिकेटेड कोई टीचर और सर्जन कोई है तो वो हमारे मुरलीधर शर्मा जी है। और उन्होंने मेरे को एंटीबायोटिक्स और पेन किलर के लिए कम करने के लिए मुझे इतना बूस्ट दिया कि मैं भी उसकी 80% बताई हुई ट्रीटमेंट से मैं सर्जरी करता हूँ। सर्जरी तो पहले भी करता था, लेकिन फ्यूरियसली मैं एंटीबायोटिक्स और पेन किलर वगैरह बहुत ज्यादा यूज करता था, लेकिन उनसे संपर्क में आने के बाद मैं सुधरा हूँ। कल तीनों अपना अपना वक्तव्य ज्वाइंट करेंगे, तो सभी को मैं प्रार्थना करता हूँ, वाह, जूनियर सर्जन एंडोस्कोपिक इज रेडी। थैंक यू।
थैंक यू सर, सभी को नमस्कार।
He was waiting for my
हाय,
closure.
हाउ आर यू?
Hi.
बाय बेटा,
Hi, sir.
थैंक यू। स्टॉप योर स्क्रीन बलेंद्रू एंड माइक
Yeah.
ओवर टू दी अग्निहोत्री सर।
Yes, sir. Thank you. I again request all the persons, if anybody is interested to say something as a suggestion, objection, any query or best wishes. We are most welcome.
तपस्वी पुत्रा जी,
हाँ सर।
क्या बताना चाहते हैं? थोड़ा आजू बाजू का आवाज कम करो बेटा, काफी म्यूजिकल इंस्ट्रूमेंट बज रहे हैं। यू कैन गो अहेड विथ योर ओपिनियन। मैं व्यक्तिगत रूप से तीनों वक्ताओं का आभार व्यक्त करता हूं। मेरे से ऊपर टाइपिंग नहीं देखने की गलती हुई थी, लेकिन उन्होंने अपना अपना बड़कपन दिखाते हुए रक्तमोक्षण की जगह पे क्षारसूत्र हमने टाइप कर दिया था, और उनके जगह पर केस प्रेजेंटेशन की बदली में मैंने कुछ दूसरा लिख दिया था। तो मैं उन दोनों से क्षमा प्रार्थी हूँ, और उसमें जो है हम चेंज कर लेंगे। और आर यू रेडी टू स्पीक? समबडी वाज देयर ओनली। सर, लगता है वो नहीं बोलना चाहते, पूर्णाहुति समारंभ शुरू करें।
Yes, sir. Thank you. मैं सभी का आभार व्यक्त करता हूँ. I just extend my all the thanks to our guest speakers of this webinar, and also Dr. Tejansik and Dr. Vijay Shri Saptah of previous webinar of today. So with these words, we again welcome and thanks, and we request that you please join again and again, because it is an endless process and journey which is going on for last 3 years and 4 months. So please join again and again. With these words, I hand over to Professor Pawan Sharma ji with the permission of Dr. Maheshangvi ji, so that both the webinars are now reached to an end. Professor Pawan Sharma ji, namaskar.
नमस्कार सभी को।
Professor Pawan Sharma ji, आप औपचारिक रूप से कॉल ऑफ करिए आज की वेबिनार का पूरा। Are you hearing me?
उसको हम 10:30 के बाद डिस्टर्ब नहीं करेंगे, उसका सोने का टाइम हो जाता है पंडित जी।
जी सर, मैं फोन करके बता देता हूँ।
नहीं, रहने दो, बता देना, आप भी खत्म कर दो सर।
रिकॉर्डिंग क्लोज करानी पड़ेगी ना, वो तो उन्हीं के एंड से होगी।
हाँ, वो फोन करके बता दो ना।
जी मैं बता दूँ।
पवन, आर यू देयर?
अपन सुन नहीं रहा। चलिए अपन लोग की तरफ से सबको नमस्कार, शिवरात्रि। कल फिर मिलते हैं।
शुभरात्रि शुभरात्रि सुखायु भव। और आज के ज्ञान गंगा में सभी जुड़ने के लिए मेरा प्रणाम। थैंक यू वेरी मच।
सो क्लोज करिए अगर आप सुन रहे हैं। चलिए उनको फोन करके बताते हैं।
हाँ बता दीजिए। मैं करूं फोन?
हम भी कर रहे हैं एक ही बात, जो जिनका पहले लग जाए, जिनकी उससे
ट्राई करें, मैं भी ट्राई करता हूँ।
जी जी जी।
ये क्या बोले, बनेगोल सर है?
नहीं है सर, बेनकल सर।
ठीक है बालेंद्र, तुम्हारा क्या मतलब ओपिनियन रहा आज का?
बाला रेड्डी जी।
बाला, अजीत यू आर देयर?
हाँ सर।
यस सर, यस सर।
क्या कहना है तुम्हारा?
सर जो ब्लड लेटिंग के ऊपर थोड़ा कंफ्यूजन है, क्योंकि उसमें इतना हम कन्विंस्ड नहीं है कि ये हम इतना बड़ा प्लेटफॉर्म में इंटरनेशनली उसको साइंटिफिकली प्रूव कर सके। ये थोड़ा मेरा विचार है।
अभी चर्चा करनी है कि बाद में पर्सनल करनी है?
नहीं, ऐसे आप बैठे हैं इसीलिए। खालकर सर है और आलोक सर है और आप है, तो फिर मौका ही ये मौका है।
क्वेश्चन किया था, इसलिए क्वेश्चन किया था जैसा आपने बोला ना, ये तो एनाटॉमिकल डिफॉर्मिटी है वहाँ पे।
वेरी नाइस, वेरी नाइस। मतलब भाषण सर का उसी मतलब वो इतना पुराना है, लेकिन उनका विचार देखिए कितना अपडेटेड रखते हैं। ये सबसे बड़ी चीज होता है अच्छे गुरु का।
एनाटॉमिकल नॉलेज।
हम लोग भी तो स्टूडेंट है, देखो ऐसा है कि